it was just, thank you, for giving me life to be with my family.
The gift of life during the season of giving. One woman needing a new heart didn't need to wait long. We hear how fast her recovery has been just 2 months after a holiday spent in the hospital. And good morning. It is Tuesday, February 21st. I'm Jessica Lovell, and welcome to the Morning Medical Update. Waiting for an organ transplant can take months, even years in some cases, but the woman you're about to meet spent just 27 hours on the heart transplant list. We're going to hear her story, learn what determines those wait times, and see what recovery from such a serious operation really feels like. I want to turn to our guest this morning. Jackie Adams joins us this morning from Mulvane, Kansas, outside of Wichita. Jackie, good morning. How are you?
I'm fine. Good morning.
Oh, so good to see your face. Can't wait to see how you are doing. Joining us in studio is Jackie's cardiologist, Dr. Herrick Shaw. Hi, how are you?
Hi, thanks for having me.
Good to see you. Alongside him is Dr. Andrea Vidich, also a cardiologist here at the health system and director of the heart transplant program at the health system.
Good morning.
Dr. Vidich, how are you?
Good.
Good to see you both. So Jackie, you had a heart transplant over the Christmas holiday. Less than 2 months later, you look great. How are you feeling?
I feel great. I never really was even bedridden. It was great. Nothing like I expected.
Dr. Shaw, how good is it to see your patient? I love being able to reunite people back, and when you heard she was coming on today, you were so excited to see her.
Yeah, no, very great. Jackie, it's very great to see you. You know, stories like Miss Adams, Jackie, are one of the major reasons why I chose and many of my colleagues chose advanced heart failure as their profession. I met her in June of 2021, and at that, or 2022, sorry, and at that time you were very sick. I brought her into the hospital. We got an echocardiogram. She had one of the most impressive hearts I've seen, one of the biggest hearts I've ever seen. And we started her on a medicine called dobutamine to help her contractility as a way to bridge her to eventual heart transplant. And to see where you were a year ago to where you are now, this is why we do what we do for these types of results, and so I'm very glad that you're doing very well.
So we mentioned off the top your wait time was quite short, just 27 hours from when you were actually put on the list. What was it like, Jackie, when you got that call and said they were ready for you?
It was crazy. I was in the middle of making supper, and it was actually said no caller ID on my phone, so I about didn't answer it, but I thought I better answer all phone calls from now on. And they said, "We found you a heart," and oh my gosh, I was floored. Just floored.
Yeah, docs, I would imagine once you go on the heart transplant wait list, you tell your patients, don't turn your phone off. Don't step out of the room.
Yeah, it's like
Answer
you're on
every
call
call.
24/7.
Yeah, absolutely. Yeah. Is it pretty rare, though, Dr. Shaw, to get that call that quickly? I mean, one never knows, but do you see that typically? Somebody wait within a day, they're getting the call?
You know, it doesn't happen all the time.
Right.
You know, I think Miss Adams had, a few different circumstances that led to that quick call. She had a blood group that is the rarest blood group, and with her body size, finding a match was not very difficult. And so, we found patients at our center that our wait times are, very good. We can get our patients transplanted. 27 hours, I would say, is not the norm.
Well, you barely have time to get used to the idea that you've been put on the list, and then a day later, you're thinking you're at least going to wait weeks and months, maybe.
Agreed.
So.
But me and Jack have been through this I met her last June, so we've been talking about this for a long time, and certain circumstances we had to put her on the list, in December, and but I think for the last 6 months, for the 6 months I met her, we've been preparing for that moment, and it just happened a little bit faster than I think we expected, but it worked out well.
That was a good whiplash.
Yeah.
Well, and we're going to talk more about that, because it's not just getting put on the list. You've got to prepare to get put on that list. We'll talk about that in a moment. Dr. Vidich, though, what dictates how long someone might wait for a transplant? I mean, we know the circumstances that are behind someone being able to donate a heart. We understand that. But on the recipient side, tell me about that.
I mean, excellent question. Most patients say, first question they ask, I'm on the list, how long am I going to wait? So it's size of the person, weight, height, weight, blood type, antibodies, and we also look at through right heart catheterization, what is there, what we call pulmonary vascular resistance, to determine what kind of donor we can accept. And over time here at KU, we have become more aggressive at managing donors and accepting donors. Where we used to decline them for different reasons. But now we are more comfortable dealing with more difficult or what we call marginal donors. Our acceptance rates has skyrocketed over the last 30 months through basically better donor management and accepting the hearts that really fit well for our patient that is in front of us, instead of, oh, this heart is good for everyone. It's more like, does this donor fit our recipient, and really have been more personalized donor to recipient matching than what we used to do. Like, well, this is a good heart for everyone.
More specific criteria.
Correct.
If you want to read more about our heart transplant program here at the health system, we're going to put a QR code and a link here on your screen. You can scan the code or go to the website bit.ly/newheart in all caps. Jackie, after your transplant, you spent only a few days in the hospital. Tell us what those first days were like in recovery.
The first couple of days I don't even remember at all. And the third day, I guess that's when they got me walking. I believe I just walked from my bed to the nurse's station. Not very far, but they had me walking on the third day. And I mean, the pain was nothing like I expected. I mean, yes, there is some soreness, but nothing like I expected. I mean, I thought I would be down for a long time.
But you felt that immediate bounce back after getting your new heart?
Yes. Yes.
So Jackie felt pretty healthy. Oh, go ahead, Jackie, please.
No, I just think it's just happy to be able to get it done, you know, and not be in the pain that I was thinking I was going to be in. So I think that made recovery a lot easier.
Well, yeah, and just the anxiety of waiting when you're going to get that call. She didn't have a whole lot of time to wait for that call, as we've learned. But Jackie felt really healthy really quickly. We know that 27 hours is pretty rare. But is feeling that good, and what you were seeing when she was walking to and from the nurse's station, is that pretty typical in recovery?
That's what we hope for.
Yeah.
For these patients, I think we put a huge emphasis on, what we call prehab before major heart surgery. And we really work on our patients really, walking, trying to maintain their strength. I've talked to Jackie a lot. As like, we had a set goal, a weight goal, and every day I saw her in clinic, I was like, did you get to that weight goal? The stronger you are going into surgery, if you're able to walk into the operating room, before major heart surgery, the chance of you doing well afterwards goes up much higher. And so I think a lot of it, a lot of credit goes to you, Jackie, because you really worked on trying to build up your muscle mass, try to build up your strength going into the OR, and that translated into a recovery that is exactly what we want. And so that's what we hope for all of our patients, is to have as rapid recovery as Jackie did.
So she was naturally a good patient, but she was a good patient. She was doing what you told her.
She did exactly what I was supposed to do.
Doctor's orders. Dr. Vidich, that's true. The healthier someone is going into a transplant, the better they do?
So it's not, if you look at Jackie's, it was basically predominantly, her heart was affected. All her other organs were not affected. So she was not very healthy based on her heart, but everything else was preserved. She had good management by Dr. Shah in preoperative period. She had excellent surgery with our surgeons. And then I think what separates KU from most other centers is, that nursing staff, physical therapy afterwards. They're very aggressive getting her out of bed. Post-op, as soon as she has to be, she's, sitting in chair, she's doing stuff. So it's not, we say, well, if surgery goes well, everything will go well. Well, I think it's just, pre-op management, surgery, and then post-op management, which is mostly directed by our nurse practitioners and our nurses and physical therapists, which is most important. And if you look at statistics from KU comparison to nationally, our mean average mean length of stay is 9 days, and nationally it's probably twice that, because of everything, all the efforts we put into getting patients on the list, making sure they stay healthy on the list, make sure they continue to do what they're supposed to do, and then aggressive physical therapy after they are transplanted.
Did you say prehab?
Yeah.
Did you say, I like
Yeah,
that
yeah.
term.
Yeah.
So you have rehab and then you have prehab. I like that.
Preparation before it all.
Jackie, thank you so much for letting me and Alex, our photographer, come in and visit with you while you were in the hospital, right there at your bedside. You were so candid with us. You were very emotional. We talked to you after the transplant. You said that the date that you got your heart was so important. Let's listen in.
I had a best friend, that's why I said I'd probably start crying. Okay. But she died 3 years ago, and I got my heart on her birthday, December 21st.
Really? That was your birthday present. Tell us about your friend, Jackie.
It's a girlfriend that I've known for probably 30-some years. Both our husbands played softball together. I believe that's how we met. But she had stage 4 lung cancer. So, yeah, she was real close to me.
And it made that date pretty special for you. Did you feel like she was with you through this time?
I didn't really know. I mean, because when I'm going through this, I mean, something I don't remember. Her daughter FaceTimed me, and she told me it was her mom's birthday. And then that's when I realized it was December 21st. The days are all mixed together when you're laying in the hospital.
Sure.
So.
But to realize that, that's a pretty nice moment. Jackie, let's go back, though, before all of that. And when did you realize something was wrong with your heart? What were you feeling like?
Well, I had COVID, I believe in September, and I went back to work after I had COVID maybe two and a half weeks. I was pretty sick. Then I went back to work, and I noticed coming from my car and going into work, I was kind of running out of breath. But I thought it was just getting over COVID. Well, one night in December, I was at home, and I just couldn't catch my breath, and I thought it was like anxiety, but I couldn't breathe. So my daughter, Natalie, took me to the emergency room, and that's when they found out my heart was not well.
Dr. Shaw, we're still studying the links between COVID and the heart and heart problems. We've talked about this for the last 3 years. Will we ever know if COVID was the factor here with Jackie?
Yeah, I think that's a great question. I think it's, looking in retrospect, taking a look at her heart and how dilated it was. I think this probably predated her COVID diagnosis. I think this has been going on for some time. And I think we're obviously still learning a lot more about COVID. And again, this is not, from the evidence, my opinion about, what this could have been is that it might have, could have, unmasked her heart failure. It could have been that second hit that made her symptomatic from her heart failure, but might not necessarily have been of the direct cause. Because of her cause of her cardiomyopathy is most likely the way it looked on the echocardiogram and how the autopsy looked is that this is what we call non-compaction cardiomyopathy, which in the majority of cases is a genetic condition, and which then could have COVID, accelerated or unmasked that cardiomyopathy where she became symptomatic. That's kind of my theory of how this came to be clinically relevant. But the etiology of it, I think, is probably genetic in nature.
Sure. And Dr. Vidich, add to that, because it's fair to say we just simply don't know yet, right?
Yeah. And we have gone back and forth, even is it safe to take hearts from patients who have COVID, but heart is not affected. And we have actually, with Dr. Zubair Shah, we have actually published some data that suggests it's safe if patient's heart is not affected by COVID with no elevations and enzymes and everything else. It is safe to take those hearts. In Jackie's case, based on the pathology of the heart, it is really clear that she has LV non-compaction, and you will see a lot of times patients who have advanced heart failure, they get tipped on even by cold or pneumonia or anything else that comes in their way. They get tipped over, and then basically suddenly they become their heart failure becomes unmanageable anymore.
Right, like you said, that second hit, it's like it unmasked the problem that was lying underneath. So we know, Jackie, that your heart problems progressed quickly, but you had at first a pacemaker and a defibrillator implanted, and eventually had a PICC line. That PICC line, it's a tube that runs from your upper arm through a vein and into your heart. It's kind of like a sturdier IV. You had a little purse that you had to carry around. We have photos of that. Tell us what that was like and how you felt carrying. Well, you see thumbs up. Was it as easy as you made it look?
No, it was thumbs up. I was getting out of the hospital.
Fair enough.
The purse, I hate to complain about it because it kept me alive, I guess. But I do want to burn that purse. You forget half the time. I forget half the time that I got to take my purse with me. I drop it, and it was a long, and I was very, very thin then, and so my back was hurting. It's not real heavy, but it's heavy for someone that's thin. So my back was hurting all the time with that, but it didn't bother me. It wasn't painful or nothing. It was just kind of a pain to have to carry that black purse.
Sure. Yeah. Okay. Don't throw it up in flames yet. It'll stand as a symbol, like you said, to keep you alive. Dr. Vidich, tell us about sending somebody home with that PICC line. How serious is that? I mean, what state would she have been in to say, here, we're going to put this on you and we're sending you on your way? What was going on? I mean,
if we as cardiologists send somebody home on either dobutamine or milrinone, which we call IV inotropes, prognosis is pretty poor. And if you look at even statistically, it's worse than most of the cancers at stage 4. So it's worse than stage 4 breast cancer, worse than stage 4 lung cancer if you truly are stage 4 heart failure. So prognosis, if you look at the data, it's about 6 to 9 months. And again, even our group looked at it in our center. If somebody is on IV inotropes, their average survival is only 5 months.
So we talked about preparing Jackie to go onto that list. A big part of that was her stopping smoking immediately, Dr. Shaw. Jackie, how long had you been a smoker?
Oh, geez. Probably
decades.
30 years. Probably 30 years.
So what was that conversation like when you had to break that news to her?
Yeah, I think, smoking is one of those issues that is a contraindication of transplant because of post-transplant complications with lung disease and lung infections, and so it's an important conversation to have. With Jackie, in my recollection, correct me if I'm wrong, Jackie, it wasn't that difficult because I think she knew what the magnitude of what this meant, is that she was going to die of her heart disease if she did not stop smoking, and she was self-motivated. She quit smoking, I think, right after we, maybe even before we met, and she did really well without any smoking, for those 6 months, and that allowed us to get her on the transplant list.
Yeah, that's a pretty big incentive to stop smoking.
Yes.
Not everybody has that incentive sitting in front of them.
But it's still difficult. We still have patients, and sometimes they can't stop. It's an addiction.
No, it's awful.
And it's unfortunate sometimes, but Jackie's credit, she quit cold turkey, and what we ask our patients to do is no nicotine products at all.
Right.
No.
So you can't even wean yourself off of it.
Yeah, no like patches, no gum or anything like that, because that's something that we test for, as we are evaluating them for transplant. And so, again, credit to her. She again, still an ideal patient to do everything that we asked for and more. And so, that conversation wasn't hard because I think she knew she had her reason why she wanted to quit smoking, and that's what led her to this.
So you got a new heart, and you basically got a new set of lungs too, Jackie. How you must feel great on top of great.
I do. I can't believe I'm glad, in a way, I'm glad this happened because I probably would have never stopped smoking. But I had a choice if I wanted to live and see my grandkids get married and my kids or not. So that was an easy quit.
All right, if you have questions for Jackie and our heart transplant specialist here on the set, send your questions into us on YouTube, Facebook, and the Medical News Network. We'll get to those in a minute. You can find links to those right there on your screen, but let's get a check on our COVID count with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning. How are you?
Good morning. Good.
Hi.
It's a good Tuesday.
It is.
Yeah, right now, 57 total patients in the hospital. 29 of those are active, so our numbers did go down a little bit. A lot of that active yesterday were probably more of about administrative and removing those active signs from that patient, from those patients. But of those 29, 8 in the ICU and 4 on the ventilator. So we still have a significant proportion that have, critical illness and need to be in the ICU, unfortunately.
All right, Doc Hawk, an important part of your job is caring for HIV patients.
Yeah.
Very passionate about this and in your work. And we know that this headline is catching your attention. If others saw it, a third patient has now been cured of HIV after getting virus-resistant cells in a bone marrow transplant. First, there was the Berlin patient. That was back in 2007. Then the London patient. And now this new case is being called the Dusseldorf patient. In all of these cases, the patient had cancer. They needed that bone marrow transplant to treat that cancer. So why wouldn't we just use this for all HIV patients?
Yeah, I mean, I think the key to the answer is in your question. So first of all, these patients had HIV and then developed a blood cancer, AML or acute myeloid leukemia. You don't want that. Certainly it is much better, much safer to live with HIV if you're doing everything correctly. Taking the medicines we have now for HIV, very low side effects and can keep you healthy. You don't want any forms of cancer, especially these blood cancers. Why don't we do the bone marrow transplant for everybody with HIV? Well, that procedure in itself carries the risk. You have a depletion of your normal blood cells. You have the infusion of the donor bone marrow. You can get reactions from that bone marrow to your own body. You will have significant immunosuppression. There are just a lot of complications to this this procedure. Obviously, it has to be done in those blood cancers and things of that nature, but that's the simple reason as to why we don't do it for everybody.
Yeah, it's just too risky.
Yeah,
okay,
exactly.
That makes sense.
Yep.
Dr. Vidich, let's get back to you. You oversaw 47 heart transplants in 2022. Your team stays very busy. What does it take in a team, a heart transplant program, to pull off these highly acute cases and surgeries?
Yeah, I mean, it's team. From MAs to nursing staff to coordinators to nurse practitioners to cardiologists, surgeons, physical therapists, all our consultants, ID, critical care physicians, everyone being on the same page.
That works year-round.
Year-round, and really push towards the same goal. It's sometimes from cardiology standpoint, it's doing outreach. From coordinator standpoint, it's staying up at night, listing a patient at midnight or 1 o'clock when patient is deteriorating. And that one click and logging in at 1 a.m., your patient is upgraded at appropriate time, organ becomes available. Our surgeons being available, like Dr. Dancer Downey and Tyler Zorn, being willing to do 4 or 5 transplants when we need them to do, and the willingness to say, if we don't do it, who else is going to do it? I think the attitude of the team changed, and we became, as a team, we became really resistant to say we cannot do it. We previously would say we cannot do it, find a reason to say no, and team attitude changed to say we should do it. Let's make sure.
I love that. If no one does, who else is going to do it if we don't do it?
Correct. And that's like one of the things that, Dr. Dancer came from Vanderbilt, and that's what their mantra in Vanderbilt. And when I was in Florida, that was really our mantra.
Yeah.
Like, we should not say no to patient, because in patients' eyes, even if they have 50% chance of surviving a surgery, 50% is better than 0. So that's what we really kind of pride our team on, that ability to give patient every chance and success.
They deserve that. Jackie's transplant happened very close to Christmas on the 21st. A very busy week for the team. The rest of us think, wow, all these heart transplants happening around the holidays, around Christmas, but that's just another day at the hospital for you, right?
Yeah, I mean, I think it's the list, having patients on the list, and team being ready at all times, and that's one of the great benefit of team who's able to oversee 40 to 50 transplants. Our program has ranked 25th in the country by volume, and the quality is in top 10. And in just not transplant, we are doing what we call left ventricular assist devices, and we have done 48 last year. So the team stays busy and they stay ready. So from OR staff, they're always ready to go when our surgeon calls them, and that's really the great benefit of young and enthusiastic team.
And something that you both have always said is, like, you know, the surgery on the day of the surgery is one thing, but it's all of that prep work that's going in every single day, and the work of those coordinators and all of the testing and the, you know, going through all the processes. It's a big team effort. Couple more questions for you, but I want to get back to Jackie and ask her just, we saw that thumbs up as you were heading out of the hospital. I can imagine why. What has recovery been like out of the hospital? I know that you are loving up on those grandkids.
It's been great. I came home, we opened up Christmas presents, and I really haven't been bedridden at all. Maybe a couple days I worked, you know, kind of overdue. I kind of overdid myself. But I went shopping with my sister, I think like 3 or 4 days later. And I mean, I've just been feeling great. Really good.
Okay, you mentioned Christmas, and well, you were in the hospital during Christmas. You missed that family time. Here's what you said when we spoke to you at your bedside in December.
I really thought I was not going to feel like this afterwards. I thought it's going to take a long time to heal. I'm never going to get home to my grandkids, and because they're waiting for presents. I told them to open up, but no, they want to wait for Mimi to get home.
All right, so Mimi got home, and you all opened them together?
Yes.
And you've been going and doing stuff ever since?
Yes, I have. Going nonstop.
We're so happy. Are we going to? Do we have some photos of your grandkids? Are we going to show those photos? There they are. Your pride and joy, I know. Some of them. How many do you have? How many do you got?
I have a 15-year-old Rocky, and Jillian is right there. She's 12, and Cash, the little boy there. Or that's Gracie. She's 4, and then Cash is, or there's Cash, and he's 9.
Fantastic. You got a lot of life to live with them.
Yes.
So, Jackie, as we all know, getting a new heart and a chance at life means that someone else lost their life. What is your message to your donor's family?
I'm just sorry for their loss. I mean, I can't imagine. I want to thank them because they're giving me a second chance of life, you know, but I feel bad for, I mean, I'm happy for what I got, but I'm sad for someone losing somebody in their family, you know.
But you honor them by living a great life now.
Yeah.
And we thank you for that. We always talk about them being a good steward of the heart, right?
Yeah.
You take an organ and then you care for it, and you think Jackie's just such a tremendous patient to do so, right?
100%.
100%. All right, so do we have any reporter questions on the line? Nope. Let's get to our viewer questions. Russ is asking, how long do people need to stay in the hospital after heart transplant? We talked a little bit about that earlier. You know, some people, it just depends on how they come into the hospital, how soon they get out of the hospital. Just can you add anything to that?
I mean, need is probably 7 days. After that, it all depends how patient progresses. We do perform a biopsy before they are discharged to make sure there's no rejection. About 15-20% patients do have rejection within their initial stay. So that is treated differently early in post-op period than it would be later. So that's what one of the requirements prior to discharge. We keep them for the first biopsy.
Jenny wants to know, Dr. Shaw, why was Jackie not considered for an LVAD, or was she?
Yeah, no, that's a great question. So,
and tell people what an LVAD is,
yeah,
so they understand.
LVAD is a left ventricular assist device. It's a surgical procedure where you open up the chest and put a pump directly into the existing heart. Then that's connected to the main blood vessel, the aorta, and that pump basically takes over the work of the left ventricle, pumps blood from the heart and shoots it into the aorta, and kind of restores normal blood flow. You know, we had a long discussion. You know, again, like Dr. Vidic has mentioned, our team is, you know, very cohesive, and you know, we talked about an LVAD for Jackie to bridge her to an eventual heart transplantation, but there was 2 issues that arose. One was the body size. You know, the pump is still, you know, it still has a decent size to it, and there was not a lot of space between her heart and her ribs, when that could cause a lot of issues in someone of her size. And the second goes back to her diagnosis of this non-compaction cardiomyopathy. She had basically non-compaction. Your heart is supposed to be this compact kind of tissue layer of muscle. But when we're all born, it starts a little spongy, and then it gets compact as we, grow older. For her, hers always stayed spongy. And so basically her heart was very large, but inside the heart there's these little finger-like muscles that are coursing through her ventricle, and when you put the pump in, it would interact with a lot of those trabeculations is what we call them. And so her anatomy did not was not just feasible for an LVAD. So the combination of her size plus the non-compaction diagnosis, we thought a direct-to-transplant route was safer.
So usually people go on the LVAD to it's like the bridge to transplant.
Yeah, we either do a bridge to transplant or sometimes destination therapy if there's something that prevents them from having a transplant, for example, cancer or smoking or weight. LVAD, the LVAD survival now has gotten very good within the most recent data. 50% survival is greater than 5 years, and so. It's still a great option, and I think again one of the greatest things about being at KU is that we're equal in LVADs and transplants. We offer patients both, and and since our surgeons and our cardiologists and our staff are proficient in managing both, we really truly offer both as a therapy, and sometimes one is better than the other for a particular patient, and we have I'm proud to say that we have that ability to do both very well, and so we can tailor it to the patient.
Last questions from Tony. With as much as Jackie loves her grandchildren, can they get genetic testing to see if they too have what their grandmother has?
Yeah, I think genetic testing I think is very, very important in someone with non-compaction cardiomyopathy. And so what we'll do is end up testing Jackie for a gene to see if she has that, and if there is a gene that we find that is what we call pathogenic, then we can use that gene to screen family members. To see if they have that gene. And if they have that gene, it doesn't mean that they're going to develop the disease, but it means that they need to be watched closely. Sure. Get serial echocardiograms, get serial assessments by cardiologists.
So even though Jackie had what she had, she may not carry the gene.
Yeah, sometimes we might not find a gene.
Find the gene,
per
gotcha.
se.
Okay.
Again, I think we're learning a lot more about heart failure and these kind of what we call cardiomyopathies. A lot of them have a genetic underpinning to it. And we've done really good in advanced, with genetics to find out, but we still have a lot to learn, and so there's still some genes that we don't know yet, but there's still a lot of genes that we do know, and if we do know it, that's actionable, and we can, change management for family members going forward.
Let's get to our final thoughts today. Dr. Vidich, I'm going to start with you.
I think it's very important to continue to see cardiology, and if your symptoms are not controlled with what we call guideline-directed medical therapy, because we have 4 pillars to treat patients with heart failure, is seek help with the advanced heart failure team. And I think I want to thank from our administrators at KU to our MAs and all the staff that has helped us come thus far. And it takes a lot of effort from everyone involved to go from doing 0 transplants to some to 20 to 40 and almost 50, and the program continues to grow. And I think we are proud to say that we are largest transplant LVAD program in our region, and it's very it's a pleasure to work here and get support from all our consultants and everyone else.
Right, keep it going. We love that. Jackie, I'm going to let you jump in with your final thoughts.
I just want to say thank you to Dr. Shaw for hanging in there with me through this whole journey, and Dr. Vidich for booting me out of the hospital earlier than I was expecting. I'm glad. And the KU nurses, every single one of them were awesome. Awesome. The whole staff there is awesome at KU. And just want to thank you for that second chance of life.
Thank you, Jackie.
Thank you.
Thank you guys so much.
And thank you for letting us share your story today. Enjoy your grandkids and enjoy your new life and your new lungs and your new heart and all the good stuff. Dr. Shaw, final thoughts. I'm so glad you were able to be with us today to see Jackie.
It's great. I mean, moments like this, again, really justify, that I think I made the right career choice, seeing patients like this. And And so it's very good to see you. And to echo Dr. Avidich's thoughts about, the team, I think the team is really great, but I think it really starts with, great leadership. And so he's the first one to not, take any, praise for himself, but his vision and Dr. Dancher's vision have really transformed our heart transplant program. And I think I'm very excited for the future. So he deserves a lot of credit.
So right
too.
back at you,
Yeah.
Dr. Vidich. Good work. Thank you both so much. Dr. Hawkinson, final thoughts.
Yeah, I'll just say right back at both of you. I mean, just so excited for the future. We're hearing about this, these transplants, improving people's quality of life, keeping them alive longer. We've heard about, another person who's cured of HIV. Again, although you don't want to have to be in that position to get that, we know that it is there, and we continue to move along with progress of science and faith and all of that stuff. And I think it's just a great time we're living in. We will continue to see increases and improvements in medical care, but most of all, it's about the people. It's about the people working here at the University of Kansas Health System. Those medical teams all working together, all working for that one purpose, and that's just to make you better. So.
Dr. Hawkinson, thank you so much. Thanks to all of our guests today, and thank you for being with us. We will see you back here tomorrow at 8 a.m. How old is too old to get a new heart? I'm Jessica Lovell. When a 74-year-old man was denied a chance at a second heart, he headed straight to the University of Kansas Health System, where doctors saw a person, not an age. Join us for the next Open Mics with Dr. Stites, Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.